Hello, everyone. Good morning. My name is Deb Fuster. I'm the Director of Policy and Advocacy at the Victorian Council of Social Service, VCOSS, and I'd like to welcome you to this VCOSS webinar on climate, health and gender, women leading change at the energy health hardship nexus. As I mentioned, VCOSS, Deb Fuster, Director of Policy and Advocacy here. It's my pleasure to be part of an amazing two-year project funded by Energy Consumers Australia, looking at shifting and connecting policy, program and practice across the energy system and the health system in order to break this nexus between energy hardship and health hardship. Before we get underway, I would like to acknowledge country. I'm coming to you today from the heart of the city of Melbourne in Victoria. I'm on the lands of the Wurundjeri people of the Kulin Nation, and I would like to pay respects to elders and ancestors, to emerging leaders and to any First Nations colleagues on this call today. And I would like to particularly acknowledge the First Nations leadership in the health equity space, in the energy consumer space as well, and calling out the work of First Nations led organisations such as Original Power. So thank you to all the incredible kind of leadership and very sophisticated systems work that is happening in that space as well. As I mentioned, this webinar is brought to you today by VCOSS as part of a two-year project funded by Energy Consumers Australia. We're very grateful for this support. These types of gatherings, these webinars are part of a multifaceted program that's involved original research, literature review, critical friends groups, provocation papers. The list goes on. You can find all of the resources around this project on the VCOSS website. If you go to vcos.org.au, there is a particular resource page around our energy health resources, including our latest winter warmth campaign as well. In terms of locating today's session in that project, we know that the intersect between our changing climate, energy and health is clear. Shifts in temperature and extreme weather events are increasing the demand for energy, but the cost of living crisis and unaffordable utilities is putting a safe home out of reach for many who need it most, leading to quite disastrous health impacts, all of which are eminently preventable. We know that studies from the Kids Research Institute in Australia show that over time, climate change will devastate children's health with a 60% increased risk of preterm births and high incidence of respiratory disease, putting more children in hospital and compounding this. Women we know are often the first responders in times of climate-related disaster, often taking on that responsibility for rescuing children and older family members and supporting their communities, as well as liaising with local emergency teams. Women can advocate for healthier communities by making the case for action on issues such as housing, access to green spaces, advocacy on pollution. And we're really we're excited to be joined today by two inspiring leaders who are laying the foundations for women to take a leading role in climate adaptation initiatives to tackle the energy climate health nexus. So it's my pleasure to start today by introducing colleague, Associate Professor Zarina Lomish-Tompkins. Professor Lomish-Tompkins is going to present on exploring climate resilient maternal and child health, setting research priorities in Australia. And her interdisciplinary work explores how climate change and disasters can affect access to care for women and children, particularly in the Asia Pacific region. Zarina draws on her background, particularly in nursing and digital health, and collaborates widely to support gender responsive, community-led adaptation efforts. She's committed to mentoring and working alongside early career researchers to build evidence-based practical solutions that strengthen healthcare systems in an increasingly uncertain climate. So we're very excited to have her with us today and pleased to listen to this presentation. Thank you so much.
Thank you, Deb, and to the VCOSS as well for this kind invitation to present our work today. And I also would like to acknowledge the country and acknowledge the traditional owners of the lands in which I live and work here in Naarm, and that's the people of the Kulin Nation. And I acknowledge and pay my respects to elders past, present and emerging. So let me just move my slide. Okay, so over the next 20 minutes, I would like to speak to you about the work that we are doing here at Monash University. It's actually crossing 5 nations, that is Australia, Indonesia, Malaysia, Fiji, and Bangladesh, in context of what it actually means to have a climate resilient maternal and child health. And we not just looking at the healthcare systems, but also community needs. And what this actually means in terms of trying to prioritize where we do most of our work in the context of resources that we have available, but also how do we connect with all the other sectors that exist out there outside of health. As Deb mentioned to you earlier, I do come from the health background. I am a registered nurse, my expertise in pediatrics, but across the time I've also developed expertise in health informatics. And so these days we combine those two to try and bring solutions to the table. So overall, the presentation will focus on three main key elements. Is one, which Deb sort of preempted a little bit, which is to do with climate change as a risk hazard to maternal and child health and what that actually means and it looks like. But also, what do we imagine these services might look like in the future and what the needs are across the time, both from that system point of view, but also from community point of view. And then, of course, we'll tell you about the work that we have done, both in terms of mapping of what interventions exist, what we know works and doesn't work across the globe, and then what is our community telling us that we actually need to be thinking about, at least in the early sort of stages of data that we are collecting. I also want to highlight that in the context of maternal and child health, our definition is actually a lot broader than the typical maternal and child health nursing definition, which is usually when the child is born and sent home up to the age of 5. We actually look at a much longer span, which is in the context of maternal health, all the way from conception, pregnancy, childbirth, and postnatal period up to the 5 years of age for the child. And the child health is actually referring to the health of children, again, from conception to under the age of 5. And this fits with the World Health Organization definitions of what maternal health and child health is. And it also allows us to cover that continuum, because if you think about it from the usual cultural point of view, is that the maternal health doesn't stop when you're just pregnant or just give birth. It actually is very closely connected to our child's health and how that health evolves over the first 5 years and beyond. Those with older children will know that you never really stop being a parent. And in context of that 5 year gap, it's actually about that close connection and children really depending on mothers for that provision of care in that early development. So when we think about climate change as a risk hazard to maternal and child health, this really sort of links back to the United Nations disaster risk reduction definitions in terms of thinking how do we prepare, respond, recover, and then actually review what's happened in terms of context of this hazard and then respond better next time. And certainly our research has taken that approach because it is not something that will always be sort of responded to in the same way, but rather it will evolve. And this becomes very important because as the carbon emissions continue and we're not reducing what's actually getting into our atmosphere, we're entering into a stage where we are going to go about 1.5 degrees Celsius. And then the question becomes, what is this climate going to look like? Because the modeling sort of predicts what this might look like at the global level at 1.5, 2, or 4 degrees Celsius. But fundamentally, this is modeling. We don't really know the reality of it. And many of these models, they look at the larger scale, and that micro modeling that occurs in our suburbs and in our towns is still relatively uncertain. So that means that any preparation to address these risk hazards has to be really dynamic and responsive, and the adaptation and resilience building that is coming in this space also has to be responsive and adaptive, whatever that challenge might look like. And so if you're looking at the climate change from that risk hazard perspective, you're kind of looking at the direct effects. And we all know that with climate change, there'll be an increase in frequency, duration, and intensity of the natural hazard disasters, such as storms, droughts, floods, heat waves. But then also one thing that is missing from this screen, and it's important for coastal communities, is sea level rise and salinity. And then, of course, there is the impact on what happens in terms of water quality with all these changes occurring, salinity being the thing that comes to mind, the air pollution as more carbon and pollutants enter the air, what happens in terms of land use and degradation, deforestation, and all the things that occur as we do not go down the sort of mitigation components that we should as much as we should, and then the ecological change that is occurring in our environments. And interestingly, from the health perspective, when we talk about environment, most people think about that immediate environment, which is your housing and who's waiting for you when you go home to look after you and so on. And the context of natural environment, both for maternal health and child health, really hasn't actually been considered so much until about 10 or so years, when people have really started to think about this at the bedside table. From a policy level, the information has been there for about 25 years onwards, but that sort of trickling from policy down to implementation has been lagging quite a bit. And then, of course, these direct effects and indirect effects are complex by social dynamics and what occurs in terms of age and gender, the health status that the child or is born with or that the mother has, and socioeconomic status, social capital. All these things impact. It's that systems thinking point of view in how we not only experience the illness that we have, but also how we participate in recovery, how do we participate in terms of disaster preparations and so on and so forth. And that means that all our climate adaptation and resilience responses have to take these things into consideration, because one plan does not fit all. And if we look at the most vulnerable population, if we address the needs of these vulnerable populations, or as we prefer to call them, at-risk populations, then everything up the chain will also be catering for the rest of the population, because we've looked at most social needs that are required to address in these contexts, and health needs too. So as mentioned earlier, in terms of pregnancy and early childhood, these indeed are critical windows of vulnerability. And that comes predominantly from the biological perspectives, because pregnant women, for example, will experience significant changes in their physiology that will enable them to manage heat exposure very differently, for example, or the stress related to disasters or mental health recoveries. And very similar with the pregnancy, if you think about the development window all the way from the conception to birth, at every point, as the child grows, as the cells divide, as the DNA changes and basically dictates the new development of a limb or an arm, that fetus or that child is actually, subject to all the external influences that might impact how that child develops during pregnancy. And then there is the thing that occurs during the actual birth and post-birth and so on. So a lot of times during heat waves, for example, there is the potential of fetal distress. There's definitely potential for the pregnancy or the pregnant mother to experience the hypertension, which then could lead to restricted fetal growth and so on. And that, threat continues through pediatric health under the age of 5, and it doesn't stop there. So you have to think about it as a cycle that occurs across the time. And so what it means is that when we're thinking about the risk hazard addressing and adaptation, we have to be considering the physiological aspects, the environmental aspects. What does this actually mean in terms of interventions, and how these can then be implemented in order to protect health over time? I also want to point out that at this stage, we actually don't know what the paternal health impacts might be and how that might be impacting the offspring development. And I think that is also another area of research that will be contributing down the track as well. So what would then climate resilient maternal and child health look like? Well, if you look at the World Health call to protect maternal, newborn, and child health from the impacts of climate change, a lot of this plan focuses on what the community wants and needs, and this will be regionally different. It will even be different among the cities, rural, and regional areas. But really what it means is to actually protect against current and future threats that climate change might induce. And again, taking that uncertainty into account. It still calls for mitigation, so reducing the greenhouse gas emissions and protecting the natural environment from further degradation, but it actually predominantly also calls for investment in infrastructure, diversifying supply chains, and strengthening the natural systems that might be around these systems. The main problem with many of these climate resilient sort of initiatives, if you like, is that there really is a heavy focus on infrastructure and building and supply chains, and they are indeed important. But where the gap really seems to be is actually educating and empowering communities in climate and health literacy, so that there is a potential to protect maternal and child health. And we all know that it takes a village to raise a child. So when we look at the climate change and the vulnerabilities of maternal and child health, we actually do go to the World Health Organization again to look at this from this component of what is the hazard, what's the vulnerability of that community, and what's the likelihood of the exposure. So, for example, what are the pregnant women doing as their employment? What's happening with the housing quality? Where is it that they actually live, and what's the livelihood type? And then, of course, that also comes down to the age of the mother. So is it, pregnancy in young age? Is it an older pregnancy, and so on? What is the access to care? So lots of issues need to be considered in terms of vulnerability and exposure, and of course that hazard. And while some of these hazards will have general elements that are common to all of them, there will also obviously be those that are specific to the hazard and how these are addressed in the context of actual health. And then whether you are rural or regional, that also and metropolitan, that then also needs to be considered in terms of what health systems are there to basically provide care. What do we then do in terms of linking to food systems and other socioeconomic and livelihood systems that need to be considered as well. The World Health Organization does provide guidance in what these climate resilient, environmentally sustainable healthcare facilities should look like. And here really the focus is again on the system as a whole, where we're looking at development of healthcare workforce, leadership, government, governance, financing. How do we deliver services or change models of care? What are the essential medical products and technologies that we need to deliver? Because one of the key issues is that if the frequency and duration of natural hazard disasters is going to increase, this will actually fatigue the healthcare system and the healthcare workforce. So what do we need to do to then actually prepare these systems to work and operate under that increased pressure? And even when it comes down to the health information systems, such as, for example, electronic medical records, if there is a natural hazard disaster like a bushfire and the internet is cut off and your systems are not working, what are these backups in terms of climate resilience? What is the minimum that we need to provide self-effective care to pregnant women, newborns and children during that time? So there's a lot to consider what this might look like, not just for maternal and child health, but any health out there that is being provided. So overall, when we're looking at redesigning healthcare systems, we want to be thinking, the robust infrastructure, the to train and support workforce, how accessible those services are during natural hazard disasters. But then from our perspective, it's also about the community-led planning, because what some group of people might need will not be responsible to another group of people, and same thing in terms of geographical demands and needs. So this then brings us to the initiative that we've actually set up that involves 5 countries at the moment, with each country mapping their own needs, but sort of triangulated as an Indo-Pacific requirement to prioritize where our efforts should be. And really, again, like I mentioned earlier, it's involving Malaysia, Indonesia, Fiji, and Australia. And our vision for this particular work is to actually create a collaborative network of stakeholders in maternal and child health that actually promotes climate awareness, so that climate and health literacy amongst communities, healthcare workforce systems, and then drives out action that would actually make a difference, not just in terms of mitigation, but the community action, so that the community is actually empowered that regardless of what's happening with the healthcare system, the community has that knowledge to act. And you can think of it in terms of basic first aid of climate change, if you like, where people do know and are prepared, are reasonably independent from the system to at least provide that first aid to protect health in context of maternal and child health. And then, of course, for us, it's also about identifying where evidence gaps are, where we need to focus the priorities to put research into it, so that there are these effective interventions that we know will actually work through inclusive input, particularly for women and adolescent girls, because in many of these initiatives, you'll see in a minute, the community, women and adolescent girls in particular, are excluded from the design of these interventions. And that might be one of the reasons why many interventions that are reported in the research literatures fail, because they hardly ever involve co-design with the communities. The World Health Organization further also provides what they think should basically come into these priorities. And for us, it will be comparing what is it that Australia, for example, needs relative to this plan, and how is it that we are different in context of geographical need, population need, and different communities that are existing in our society and so on. So one of the early studies that we did is to actually map the evidence in terms of what's actually being done in terms of supporting maternal and child health, particularly at the community level, to protect the maternal and child health from these hazards. And you can actually see that we did not identify any studies coming from Australia that actually look at this context. But we did see quite a few of them coming from China, for example, United States, and few from Pakistan, Indonesia, and India, and so on. So that already tells us that, at least from that visible evidence-based, we do need a lot more work done in terms of maternal and child health and healthcare system climate resilience, so to support maternal and child health across the future. Furthermore, when we're actually looking at the different types of measurements, what we find that many of them are top down. So the researchers come and they think that something would be a really great intervention. They actually come and implement that with the community. And what we see is that many of those things, again, are sort of not necessarily utilizing existing community services or community infrastructure to support many of these interventions to survive after the researchers are gone. We do see quite a good use of nursing and midwifery workforce in this context, but even that is limited to that initial funding without sort of sustainability plan long term. And when it comes down to looking at the interventions and what the outcomes are, a lot of the outcomes really are looking at physiological aspects of conditions. So we're looking at respiratory system, lower respiratory system tract infections. We're looking at asthma, diarrhea, for example, due to the vector-borne diseases, etc. But hardly ever do we see that systems thinking point of view in terms of what the maternal and child health outcomes are, because it's not just about the absence of disease that we're looking at supporting maternal and child health. It is actually far more beyond that, because we need to be thinking about the concepts of domestic violence. We need to be thinking about the context of what happens in housing, what happens in electricity supply and access to water and sanitation services. So it needs to be much broader than just going in these contexts of the absence of disease. The other thing that we know also is that if you're looking at the interventions themselves, many of them do not have economic cost benefit analysis. So once evidence is gained that something might work, that economic cost benefit analysis sort of stops at that point, and there is no subsequent implementation long term to support the communities beyond that implementation point to really sustain whatever's being implemented. So what we decided to do in this space is, knowing that all these issues actually exist in meeting the sort of supporting the climate resilient maternal and child health, we actually went to communities across our 5 countries, and we've started asking, what is it that you think needs to happen? And so far there's 25 planned workshops, for which we've sort of halfway through. We've just run a 3rd workshop in Australian settings, and one of the colleagues from VCOSS actually came as well to these workshops, which was really wonderful. And really the idea is to bring everybody together. So you've got doctors, nurses, community members, policymakers, anybody who's interested in maternal and child health, parents, fathers, mothers, grandparents, coming and talking in one room and actually saying from their perspective, what is it that they think the impacts are? What do they think the system needs, both in terms of service provision and service access, but also what do they as a community need to support their own empowerment to actually look in the context of supporting maternal and child health from their own unique perspective. And we are in the process of analyzing the Australian data in particular. And again, very similar topics are coming out with what's out there in the world and what I've also sort of discussed with you. But one of the key components that we don't have is the community wants to know, well, what is this data specific to my local area? What is happening within my state? What's happening within my council? How do I know what my risks are? And also, how do we know that anything that is being developed in climate resilience really is informed from the community perspective? How do we create those partnerships between healthcare professionals, policymakers, and communities, that there's this ongoing feedback in terms of what this perspective might be? The other thing that is coming through in the early data is how siloed we all work, and how little communication there is between the healthcare sector, the social sector, and the emergency management sector to try and support pregnant women and new mothers in terms of accessing shelter, in terms of accessing birth services, in terms of even having access to basics within the shelters themselves. So there's a really huge need for these conversations to start happening, and also for health to inform the emergency management sector what is it that they may need, but also for the emergency management sector to inform the health sector what they need in terms of actually meeting this gap to support pregnant women, new mothers, and young children in this context. Everybody also wants to know what the longitudinal impact will be, not just on their not just on their health during pregnancy, but also what's happening to their children as they're exposed to heat waves and as they're getting older through life. What is it that they can expect in terms of risk factors to health and well-being? There's also a need for climate and health surveillance for maternal and child health outcomes, which predominantly comes from the healthcare systems, and deciding what these outcomes are in addition to the absence of disease. So people want to be thinking about, are we looking at social aspects of things? Are we looking at housing? What else should we be thinking about in these outcomes overall? Everybody was supportive of co-designing adaptation strategies with at-risk communities, ensuring that they meet regional needs and individual needs, and also being done in a culturally sensitive way, so that what we do develop is actually meeting the needs of the communities at the time required. The mental health and well-being of mothers after disasters, and also child and maternal eco-anxiety are also prominently coming through, and people wanting to know what this looks like, not in terms of disease management, but rather people being able to act and have agency in participation in climate resilience and adaptation. So in other words, I don't just want to be diagnosed, I want to actually know what I can do this to live a life that is actually rewarding and that it copes with whatever is occurring in my environment. Everybody wanted to see the integration of climate resilience into maternal care models and wanted to review what that might look like, and what that might look like from a midwifery point of view, from the general practice point of view, from obstetric services access, and so on. And people wanting to see new models of care where pregnant women, for example, don't have to travel across the heat waves to reach obstetrics or midwifery care, but rather have service that they feel is actually meeting their needs, while also ensuring those safe outcomes for both the mother and the child. The community really wanted to take charge in terms of what's happening of the community, continuity of care, so pregnancy, that birth, post birth, and so on. And they really wanted to have workforce that was not just climate literate, but also culturally safe and climate informed across the continuum of care. And in some ways, you can think of it as in, fixing the problems that we mostly already have in the system, but then ensuring that they're actually responsive to whatever the climate might be. So I think I'm getting to the point of my presentation, and I just want to acknowledge that this is not just my work. There's a whole team of people working here, and not just in terms of the Australian settings, but internationally as well. And we are due to complete the Australian workshops at the end of this year, which case we will actually report the data back again and come up with a research report with these priorities and what this might look like for communities. And I hope to be able to disseminate those results to you through colleagues at VCOSS in due course. Thank you very much. I'm not sure if the questions will be next, but I will be quite happy to take them when the team is ready.
Fantastic. Thank you so much, Zarina. That was a terrific presentation. We are going to have an opportunity for questions and answers. What we will do is we'll hold that to the end of the webinar. We will have a good amount of time for those questions. If you just start to put any questions you have in the Q&A function, just at the bottom of your screen, we'll have those ready to go. But what we'll do next is we'll move into a presentation from one of our other inspiring speakers today. So we're very privileged to have Wenny van Riet from Gen West. I'm going to introduce Wenny now. We'll hear from Wenny with her presentation, and then we'll go to a Q&A for both Zarina and Wenny. So thank you so much. So just by way of background, some introductory comments. Wenny is originally from the Netherlands, where she studied gender and sexuality studies, completing her research masters in social sciences at the University of Amsterdam. For the past decade, she has worked in the not-for-profit sector with a focus on community development and justice, social justice. Gen West's fantastic community sector organisation, a member of VCOSS, a health service in Melbourne's West for women and gender diverse people. And Gen West is focused on, and Wenny in particular, focused on addressing the impacts of climate change on communities facing discrimination and gender depression. For the past 18 months, Wenny has been leading the climate resilience work. She's delivered the Our Community, Our Voice program, which is centred around working with identified migrant and refugee communities in disaster preparedness and recovery in an urban setting. And in addition, I don't know how you squeeze all of this in, Wenny. Wenny's also been a board member of Span Community House since 2017 and a chairperson of the board since 2021. And again, really driving climate adaptation at that local community level. Finally, in 2024, in December 2024, Wenny became an accredited facilitator for Gender and Disaster Australia's Lessons in Disaster Training. So very, very accomplished speaking off the back of another very accomplished speaking. We really are kind of leaning into that theme of women leading and driving change. So thank you so much. I'm handing over to you, Wenny, and I'll switch off my camera for now, and then we'll come back to you and to Zarina for some questions from the audience. Thank you.
Thanks, Deb. That's a very long and lengthy introduction. I hope I'll do it justice. I will share my screen and provide you a bit more information about the work that we do at GenWest. So thanks so much, Zarina, as well, for your very insightful presentation. And I'll be glad to be able to speak to a very localized approach that we've taken here at GenWest and in Melbourne's West, which is a place-based health service model, which really looks to build female leadership and community adaptation and climate adaptation in Melbourne's West. So before I do that, I'd like to recognise also that the lands on which I work and provide our services on always was and always will be Aboriginal land, and I'd like to pay my respect to elders past and present. And the artwork that you see on the screen at the moment is from Melinda Kirby, and she painted this artwork for our reception area at GenWest, and it represents women, health, land, and community. A beautiful image, I think. So a little bit about our organization. So GenWest is an organization working towards gender equity, and we're a women's health service across 7 LGAs, from Melbourne to Melton and Wyndham, and we're one of 12 women's health services across Victoria. And so since 1994, we've hosted the region's largest family violence crisis support and prevention program, and we're the only women's health service working across the spectrum of primary prevention, so really preventing family violence through education and training, early intervention by working with high-risk populations of family violence, as well as response to family violence as it occurs. So I am part of GenWest's health and wellbeing programs, and as per our agreement with state government, we focus on 6 priority areas, which include gender equality, gender violence prevention, sexual and reproductive health, which includes delivering health relationships and education at schools. We work on chronic disease prevention, mental health and wellbeing support, as well as supporting women in a changing society, which is my own portfolio, where we focus on climate change, emergency and disaster situations. And that really came to the fore when we were working, well, since the Maribyrnong River flood in October 2022. And since then, GenWest has been working with the flood-affected community to support their recovery. And we focus particularly on women from refugee and migrant backgrounds, which is reflective of that area. But before I go into the work and the specific work that we do in the local region, I just want to focus first on why we need to support women in a changing society in the first place, and just provide a little bit more context around family violence in that space. So as mentioned before, climate change is here. With climate change, we're at risk of having more frequent and more severe climate-related disaster events. And there's a very strong link between family violence and disasters. So our watch, which is a family violence peak body, has identified 4 gender drivers of violence against women. And these drivers create environments where violence is more likely to occur. So the first one is around condoning violence, and this includes behaviors like laughing at sexist jokes or making excuses for disrespectful behavior or trivializing violence against women. There is men's control, which refers to men's dominance in decision-making and the limitations that can be placed on women's independence in both public and private life. The third driver looks at rigid gender stereotypes, which includes harmful, outdated ideas about masculinity and femininity that can limit opportunities and perpetuate inequality. And the fourth driver is about male-peer relations, and this looks at male social groups where aggression, dominance, and disrespect towards women is being normalized and encouraged. So these four drivers, when combined, can create a culture that normalizes and even encourages violence against women. And so addressing these drivers is crucial for preventing violence and for promoting gender equality. Now, how this relates to a disaster and climate change is that when, in addition to these drivers, there can be many contributing factors that can impact and increase these drivers. And many of these factors occur during and after a disaster or an energy crisis or any other climate change related crisis. So we look at things like insurance battles, financial distress, reduced or no employment, homelessness, trauma, drug and alcohol abuse that can increase, or red tape when rebuilding a home. And there's a growing body of evidence that family violence increases after a disaster. And this can be both violence that is already occurring, that is increasing during a disaster or after a disaster, or it's for victims of family violence who experience violence for the very first time by their partner during a stressful time. So women are disproportionately impacted by climate change. A UN study recently indicated that for every 1 degree rise in average temperature, family violence against women and families increases by 4.7%. And in some cases, this can be much higher. So for example, in New Zealand, police reported a 53% rise in domestic violence after the 2011 Canterbury earthquake. In the US, study showed there was a 98% rise in violence against women after Hurricane Katrina. So disasters place pressures on people to conform to gender stereotypes and exacerbate existing gender inequalities. And this really causes that unequal health and social and economic outcomes for people of all genders, and particularly when they intersect with all the other inequities like racism and ableism and all the other isms. And just to give you an example of how these gender stereotypes and these social roles that we play in society based on our gender, how that plays out in reality. When we were working in Maribyrnong after the floods, we heard from a Vietnamese mom who has 3 kids, and she mentioned that she was very busy cleaning up after the flood, and she was trying to make space, and she forgot to make dinner. And only like at 9 p.m. at night, she realized there was no food and there was no dinner and her kids were hungry. And so the next day she reached out to the Flood Warriors group, which was a group of volunteers. And she asked them to offer some food for them for dinner. And so they came that day with dinner. And when they arrived, her husband was out at the front cleaning. And he told them, "Oh, no, that's okay. We don't need any food. My wife can cook. We still have a kitchen. So you should give it to other people who need it more." So that night, when it came to be dinner time, and her kids told her, of course, not her husband, but her, that they were hungry. And she asked her husband if he'd seen the volunteers come around with food. And it's only then that she realized that he had refused this food because she could cook. And that's really just one example of how gender roles can play out, and why it's so important that women are part of the change and lead the change. So giving you a little bit of example of what we're, the space that we're working in. And so I wanted to give you a bit more context about the work that we do at Gen West. So since 2021, the multilingual health education team at Gen West has been working really closely with our migrant and refugee communities in Melbourne's West. And through our peer-to-peer delivery model, we've been providing in-language, evidence-based and culturally safe health education. And being from migrant backgrounds ourselves, we've built really deep trust, supported by the commonality of language and culture and lived experience. And so we focus on really long-term relationships and engagement in community. And we focus on community leader capacity building. So we've been providing a lot of on-the-ground health education sessions about the Australian healthcare system, essential health, sexual and reproductive health, healthy relationships. And more recently, we're also working on understanding and addressing gender-based violence through a project called Sitara, where we will build women's leadership in the community to be the guiding light in their communities and the token of knowledge around family violence. And so this health education is being offered in Hindi and Urdu and Arabic or Easy English to lots of different multicultural women across Melbourne's West. So whilst we're out delivering these health education sessions, this is the Maribyrnong River floods in October 2022. It's a really dense urban area and over 500 homes flooded. And when this flood happened, we were approached by state government to provide mental health and well-being support. And so we asked, well, who's affected? And it turned out that there was a really large Vietnamese community living in this area. And so we wanted to hire a Vietnamese bicultural worker to work in this community to provide the support required. Now, when you advertise on Seek or ethical jobs, you may not actually get the right community fit. Women, and particularly migrant women, they need to be asked. So we did. So we advertised externally on recruitment platforms like usual, but we also went through our networks to see who we could ask to apply. And we found Tui. Tui at the time was a former deputy mayor of Brimbank, and she'd been supporting the flood-affected community on the days after the flood. And she'd already been attending our health education sessions. And so she'd really shown her ability to be a community champion, and ultimately she got the job. So with Tui Dang on board, we started to talk with the flood-affected community and listening to voices who hadn't been heard yet due to language or cultural barriers. And we realized that the community was not ready to consider their mental health or well-being because they were still dealing with all the logistical issues after a disaster, from insurance to trying to move back into their home. And even though they were experiencing trauma, they just didn't even have the mind space to think about mental health support because they were in survival mode. So instead of providing what we were funded to do, Tui said, no, we need to start with providing practical support. And she told us that there was this massive information gap between what organizations could offer on the one hand, and on the other hand, what community knew that they could receive. And so we worked together with local service agencies to develop an information booklet that we translated into language. And then we started handing out this booklet through door knocking and letterbox dropping and talking to community where they were at. And we also collected these stories and collated them in our report on Our Community, Our Voice, on the lessons of the 2022 Maribyrnong River flood, which is based on really in-depth interviews which were held in language on the experience of migrant women and their flood recovery and that experience. So in the end, we were funded for 2 years, and we delivered many health and well-being sessions which were really tailored to community. Another example of how we've worked with women to lead change is a more recent project where we worked with the Maribyrnong community on developing a flood insurance guide. And this came about because we'd heard how insurance had impacted people's mental health. And so we partnered with Maribyrnong Council to work with community to deliver an insurance support program. And so when this project kicked off, Tui Dang was no longer available to work with us because she's now elected as mayor of Brimbank City Council. So we asked her for advice, and she said, you need to hire Quinn. Quinn is a local affected Vietnamese resident and a true community champion, but she would never call herself that. So you may ask, what is a community champion? A community champion is really a trusted member of the community. It's that person that everyone knows and who they call for when they need help, but also when they want to celebrate a win. They're kind of like the glue connecting people. And they may not have any official title to do so. It really happens organically. And so we've asked Quinn to help us. She was really excited, and we paid her for her time. And together with our existing bicultural staff, we held conversations about insurance in community. And as a result of those conversations, we knew exactly what community wanted, and we were able to deliver a resource and answer the questions that they wished they had the answers to before the flood happened. So I'll just very briefly share a video of Quinn talking about the guide that we created with 8 community organizations and 3 community members in just 6 months.
I thought that I know everything already until I get to read this guide in Vietnamese and in English. The stuff that I know is only a very small percentage of what's in here. There are so much more information in here that will help everyone in Australia that will go through a natural disaster or flood. So if you can't get your hand on one of these, please download.
So in summary, in our work, we use a peer-to-peer delivery model, which is best practice when engaging migrant and refugee women in mental health and well-being support. So we respond in a culturally appropriate and gender responsive way, which means that we always consider what's culturally appropriate to deliver, what time and in what way do we engage, in a way that everyone can attend, whether it's mums or children, people with mobility needs. And we do this because we work with the people in community, and so they tell us what they need. We work with a culturally competent and bilingual workforce, with female community champions as our trusted community experts. We partner with community champions and cultural groups, and we work on ground with, for example, Quinn in the flood insurance guide, and we make sure that we pay them for their time. We build connections based on commonality of language, culture, and lived experience, and we really build trust through long-term engagement. So we don't just dip in and out. We build really strong relationships in community and make sure that people are calling us, not just when they need us, but also when they have something to celebrate or just want to have a chat. And finally, we focus on that community capacity building and building on the strengths in a community to enable community champions to take the lead on what they need to do. And so as a result of this work, we've been acknowledged by the Primary Health Network as providing a masterclass in community engagement. And we're now using this model to deliver climate adaptation sessions and climate adaptation work in Melbourne's west, in Wyndham and Melton. If you want to find out more about our work, please head to our website or send me a direct email. Thanks so much.
Much for that fantastic presentation, Wenny. And I now invite Zarina to also be part of this Q&A. So Zarina, if you'd like to switch on your camera back on again, fantastic. Welcome back to this Q&A session. As I mentioned earlier, there is a Q&A box or function at the bottom of your screen. So please put any questions that you've got in there, and our expert speakers will be pleased to engage with your questions and further conversation. I guess to kind of kick off, Zarina, if I might go just back to your presentation for a moment, one of the things that you observed is that the kind of early data from your current work is highlighting how siloed current efforts are. And I guess for VCOSS, looking at kind of our breaking the energy health hardship nexus, a big focus of this work is about how we kind of shift, how we connect up existing work in and resources in the energy system, energy market, and our health system, and how we also like work to not only connect up what's there, but also shift at a kind of program practice policy level as well. So I'm just wondering, you know, you've done some great work engaging healthcare workforces. It can be really hard to engage healthcare workforces because they are so time pressed. So much of their work is codified about how they spend their day as well. I'm interested from your kind of work on your current projects, the kind of networks that you're involved in supporting and convening, but also just as an interdisciplinary researcher, any kind of insights that you can kind of share for us about how do we break down those silos? So what's in our locus of control in terms of our practice, but what are those kind of systems enablers as well that we need to kind of keep pushing for as well? Do you have any reflections or insights that you can share with us on that, Zarina?
Wenny actually touched upon this really nicely in her presentation, which is you really need champions, and sometimes a lot of background work is done in trying to identify who these champions are because they are foot in the door, so to speak. So for some of our work, it's taken over 4 years just to get to a person, to get somebody to respond to us in terms of the organization even wanting to talk to us. I have a slight advantage because nursing is the largest workforce in the country. I'm part of the Australian College of Nursing and Australian Nursing and Midwifery Federation, and I teach in nursing, and so I'm a visible role model in nursing. So when we call upon nursing profession in order to meet particular need, we will have people who will respond to this because we are known for championing particular type of cause. And that then through those networks, we've got the opportunity to connect with midwifery and then obstetric services. And really, it's come down to the people who understand the challenge that climate change is and what that means, not just for today and tomorrow, but 20, 30, 50, 100 years from now. And so for people who recognize what these challenges are, they see this challenge beyond the constraints of the current system, which is who's going to fund your research? When are you going to get money for this? How are you going to do whatever? And they're there with you to support the idea, regardless of when the funding will come, knowing that you and them are in this for long term. And the other thing so for example, one of the most challenging things we have at the moment is actually getting engagement from emergency management services. And we have nurses who are embedded in these emergency management services. So when we look at these networks and forming them, we don't want to put an extra burden on the emergency management services, but rather saying, okay, we're looking at this problem. What do you need us to do to help solve this problem? What is it that you need from the emergency services point of view? And who do you want to talk to in healthcare? Do you want to talk to a midwife? Do you want to talk to a nurse? Who's the comfortable person you want to work with? Because everybody perceives everybody else as busy. And that stops us a lot from having those conversations. And sometimes if you wear your heart on a sleeve and you say, I really am committed to this problem, I really want to solve this problem, if it's not you, who else do I need to talk to? Like, how do I get this off the ground? And I think, and it takes time and it takes persistence and it takes being there beyond the funding. Our funding is going to run out, but I'm available to my, people, my network 24/7, regardless of whether I have funding or not. But I think that's again driven by that philosophy of a champion, which is that I'm in this long term. The other thing is also that when people think about system design and development, because they are so focused on solving the problem, they don't often have the time to think of who is the part of this system. So mapping that system and actually taking that conscious recognition that something is a problem and wanting to solve it is really important. And that's challenging because what I've observed is that most people go into a disaster, they manage disaster, they do what they need to do. And then there's this sort of lag phase where almost everybody forgets about it in a particular way. And all these things that we've learned from those lessons don't get integrated by the system to make communities more resilient. And then the disaster happens again, and then we go through the same cycle again. So the question will always be that, if you look at the floods, for example, as mentioned in the previous case study, how do we, how do we not just support communities at the time of the need, but how do we remain with those issues visible across the time so that they remain the lessons on which we build down the track? At least that's from the healthcare perspective. Wenny will have a very different one, I'm sure.
Thank you. Thank you so much. I'm going to throw to Wenny for any comments that you might have, Wenny. But I guess what I picked up from that, Zarina, is that the work is deeply relational. It is about kind of hearts and minds as well, but it's also about smart strategic use of existing kind of system architecture. So different kind of institutional actors, different kind of networks and forums that they're convened. Sometimes they've got a statutory obligation to actually be convening those things, and it's about not understanding those, knowing those, mapping those, strategically using them. But there is this kind of persistent challenge around this is like long tail work. It's not just kind of like set and forget. We've got to kind of be able to find a way to sustain it beyond funding cycles. And that's a great kind of entry point for you, Wenny, in terms of reflections from, you as a representing a community sector organisation. We really are beset by huge kind of structural challenges in terms of how sustainable our funding is, our service kind of platform. We spend a lot of time kind of, organisations like GenWest investing in community leadership and capability, but how do you kind of sustain that in the long term? Do you have any reflections on that in terms of, I guess, systems shifting, boundary spanning kind of work in this space?
Yeah, I find it's all about relationships, as you mentioned. And I think every organization that we work with has that a commitment to meet community needs. Everyone wants to meet community needs within their funding obligations and within their remit. And so I found that when we work with community and we can very clearly identify what that community need is and provide the evidence behind that, and then we build on the relationships that we already have with other service organizations. And in the case of the Maribyrnong, it was the Maribyrnong City Council ran a social recovery committee where all these organizations were already coming together. So they already had those relationships built. And so then when we came out to the organizations and said, this is what community needs, who can help? Like everyone just put their hand up and wanted to support that work. So I think, yes, it's both relationships and just asking the question, and then see who's willing, but only work with the willing.
Yes.
That's it.
Yeah, and that does connect with actually some advice from a speaker from the UK that we had our last webinar as well. I think there's a phrase that sticks in my head from Daniela, who's from the UK, who spoke at our last webinar, which was like, in her case, she's language, find your Louise, because that was Louise was literally like her champion and kind of her way into opening up a whole heap of kind of, boundary spanning systems, shifting kind of like work. So in terms of bridging energy system and health system. So thank you for that. Just on that, in terms of building relationships, local networks, etc., there is a specific question for Zarina about whether there's a connection in the work that you're doing with legal assistance services, so specifically community legal centres working in partnership in the maternal and child health space, supporting disaster impacted communities. Has that sector or subsector been connected up with your work and your networks?
Not to the level that Donna mentions, and if Donna is interested, I'm more than happy to do that. We have connected with the legal aspects, but it's all sort of sitting at that sort of higher level where people are looking at policies and translation into policies. But I think looking down to looking towards the legal assistance services would actually be really important, because we recognize that, again, that maternal and child health in a context of climate adaptation resilience is impacted by all of the systems in which we live, and legal is definitely one of them.
Yeah, fantastic. There's also a question that was asked a little bit earlier in the chat. I might just circle back up to that one. It's I guess observing or reflecting or acknowledging that climate resilience is very nuanced and communities tend to have very unique needs. And when you've talked about place specific, setting specific work that Gen West is doing. Zarina, you've talked not so much about a specific place, but you've talked about specific kind of workforces. So health workforce is like huge, and you've talked specifically about a workforce such as maternal and child health, which again, very rooted in place. Place is a huge kind of context for that work. I guess the question is that in terms of like the work that we need to be doing here around energy health, around like climate adaptation and gender, the question is a nationally or state coordinated response out of the question? It's a huge question, I know, but just wondering what your thoughts are on that. Who'd like to go first with that? Zarina?
I was going to say Winnie should go first, because
Okay.
it seems to be more. I will tell you what I think, but I think it will be better for you.
Very complex question. I think you need both. You need to work on the ground with local communities to work out what the local risks are, and having the local conversation so that you can work out what the need is. So we're currently running a local program in Wyndham and Melton where we're looking at climate adaptation. So the first thing we did is we've had 200 conversations in the last month with community members around what's your need, what do you know about climate change, what kind of things do you do to be prepared, like what do you think your risk is, asking the question, and then we will be tailoring the supports required in that particular community based on what people have told us. But we can't do that without services already available. So I feel like we're like the conduit. So I'm now tapping into state government resources and things that are already out there and matching it up. And where it's not already created, I'm going to go back, to government or to service providers and go, hey, this is what community needs. What can we do to develop it? But very often there's so much information and support's already out there. People have no idea that it exists. And so it's actually just about connecting the dots.
Thank you. Now, I'm just mindful that we're at time. So we're going to wrap up in a moment, but I might just say there is a question here. This one is targeted to Zarina, asking about whether you've got any examples of community-led adaptation initiatives identified through the global study. I wonder, Zarina, if we might work with you offline and just perhaps there might be some links that we could circulate post-event to people. Does that sound okay with you?
Yeah, that's fine. That's fine.
Fantastic. And there's also a question or a comment from here about someone who is looking at how they can make bigger impact, and they've just noted that it's been difficult to kind of even volunteer here. So we might kind of see what kind of networks and groups we might be able to kind of connect that that person up to. So sorry that we haven't been able to get to all of those questions, but we'll take some of those offline and share the answers to those questions, links to further resources post-event. Want to just once again say thank you so much to Zarina, to Wenny for their fantastic presentations, giving so generously of their time, learnt so much from today's webinar, so thank you so much. Also again want to thank Energy Consumers Australia who are funding this project. We couldn't convene webinars such as this one or do the other work across this project without the support of ECA, so really want to express deep gratitude to ECA for their support all along the way. And finally, a big thank you to the VCOSS team, in particular Emma Halloran, who is the project coordinator of our Energy Health Nexus project, and to Deepa Prabhu, who has also been helping behind the scenes with logistics and tech today. So thank you, everyone. We will make a recording of this webinar available to everyone. It'll have an even greater distribution like post-event. There'll also be a transcript and other resources, as I've mentioned. So thank you, everyone, and enjoy the rest of your day. Thanks so much.
Thank you, everyone.
Thank you.